Welcome, everyone. Thank you for joining us today. I'm Dr. Avneet Kaur. I'm a lecturer in Department of Preclinical Sciences and Kandaya Faculty of Medicine and Health Sciences, University Tunku Abdul Rahman. I'll be moderating today's webinar titled The Cognitive Brain, Dementing Illness at a Glance by Prof. Andrew Law. The Mind Your Brain series, I think this is the fifth event, is jointly organized by Malaysia Mental Literacy Movement with the joint efforts of Faculty of Medicine and Health Sciences, the Faculty of Science, and the Center for Research on Non-Communicable Diseases, University Tunku Abdul Rahman. So Prof. Andrew Law, I'd like to introduce him to you. Prof. Andrew Law is a geriatric neuropsychiatrist. He's currently the head of Department of Psychiatry at the Royal College of Surgeons in Ireland and University College Dublin, Malaysia campus, and the Vice Dean overseeing the International Student Affairs. Before his medical studies, he read pharmacology and cardiovascular physiology at the University of Toronto and the University of Cambridge, respectively. Now, I just want to request to all of you, please don't hold your breath as Prof. Andrew's list of achievements is very long, and I'm just going to start now. He then pursued further cellular neuroscience research at McGill University and is specialized in psychiatry. Prof. Law's work on Alzheimer's disease received research awards from the Alzheimer's Society of Canada and the Quebec Health Ministry. At the University of Hong Kong, he was heavily involved in medical education. He founded the Neurodysfunction Research Laboratory, received significant funding for dementia studies, and trained several master's and doctoral research students. He has published over 50 articles, book chapters, and conference papers. Prof. Law came to Malaysia in 2016 to lead the psychiatry program at RCSI Kuala Lumpur and was practicing as a senior consultant at Hospital Kuala Lumpur. He's continuing with his research on AD biomarkers and brain stimulation as a treatment modality for Alzheimer patients. He is also active in establishing psychiatric education programs and the collaborative care model in managing patients with mental health issues. So that's all about Prof. Law. I think you must have already got the idea of what are we going to expect in today's webinar. If you have any questions, please type them into the chat box in your Zoom control panel. I'll bring them during the Q&A session at the end of this webinar. To all Utah students and staff, kindly sign in your attendance in the link posted in the chat box. Now, without further delay, let us turn the time over to Prof. Andrew Law. Prof, stage is all yours.
Hi, good morning, and thank you very much for the very too kind introduction. And I'm going to work on sharing my screen.
Yeah, sure.
Here we go. I hope this is okay. You can.
Yes, Prof. Perfect.
All right.
Thank you so much.
Yeah, thank you very much for giving me this chance to have this opportunity to share with all the attendants here that something about dementia. And I'm going to start the presentation by hold on one sec, it's not moving. All right, by this quote from a very famous American actress. Her name is Melina. She says, people do not realize that Alzheimer's is not old age. It's a progressive and fatal disease, and staggering amounts of people develop Alzheimer's every day. I like this quote because it's absolutely the whole truth, okay? And I was talking to some of you earlier. In fact, a lot of people still, not just in Malaysia, but in other countries, they still believe being senile, so to say, is part of normal aging, which is really not the case. So, well, if for those of you who can't stay for the whole session, then I just want you to take this home. These are probably the most important points that I would like to get to everybody today. Like I just mentioned, getting old does not mean just getting senile, and that you hopefully this talk will convince you that dementia it is an illness. We will talk about the different warning signs of dementia, and you will find out that not only being forgetful, it's a warning sign. There are other things as well. Yeah, unfortunately, we cannot cure dementia. Having said that, we can actually do a lot of things to improve and keep the quality of life of the patient and family as long as possible. Okay, so that means, in fact, if the illness can be diagnosed earlier, okay, meaning earlier treatment, then the outcome is usually better. Now, I will talk more about this. Alzheimer's disease is actually, some people have called it type 3 diabetes, and we'll go into the details later. And I think perhaps the most important take-home message today is that cardiovascular health and your brain, they are very much tied together. If your blood is better, the brain is going to be better as well. So let's start by talking about dementia. Sometimes I have people come up and ask me, Andrew, what is the difference between dementia and Alzheimer's disease? And really, dementia is an umbrella term, okay, that covers different forms, different types of dementia. Okay, under this umbrella, okay, we have the most common form of dementia, which is Alzheimer's disease, followed by vascular dementia. And we also have Lewy body dementia, which is closely related to Parkinson's disease. And we also have another form of dementia called frontotemporal dementia. Now, there are other illnesses that can cause cognitive impairments. For example, what we call slow virus. Remember, some of you might remember back, I believe in the 90s, there was this mad cow disease. That's actually one of the cause for dementia as well. Now, severe vitamin deficiency can cause dementia, and HIV, the virus that causes AIDS, can also lead to dementia as well. Now, people who overdrink for decades, their brain function also can get affected by that, and they can also develop dementia. Now, I haven't mentioned the type of dementia that I bolded it red, mixed dementia. I'll go into that in more detail later on. So now, as I said, Alzheimer's disease is the most common form of dementia. And it was discovered by Dr. Alzheimer, as you can see on the left. And the index patient is actually August Dietzer, as you can see on the right. She actually had a more early form of Alzheimer's disease. She has significant cognitive impairment. The memory issues is very huge. And in addition to the memory problem, she also had these psychotic symptoms as well. So just to share with you a little bit of the transcript that they later on discovered when Dr. Alzheimer was interviewing Augustine. This is part of it. As you can see that she does have problem answering to a lot of these questions, reflecting her cognitive impairment. She could not answer her husband's name, for example, here. She knew her own name, and she was correct about her age. But other than that, in terms of orientation to time and place, they are very much off. And this is just a small example of what significant cognitive impairment is entailing. Okay. All right. So what happens in the Alzheimer's brain? Now, let's say if someone is going to get Alzheimer's disease at the age of 75, okay, 75. As you can see here, this is the dementia stage, okay, when the person is having the cognitive impairment or other symptoms. Now, much earlier, you're talking about maybe 3 decades earlier on, you may already have these abnormal protein that is being deposited in the brain, okay? But the person doesn't have any symptom at all for the next 20, 30 years because the brain has a lot of reserve, okay? So, but during that time, a lot of damages, without going into the details, a lot of damages are actually happening in the brain. Until the point that, until the threshold is reached, there's no more reserve, then the person becomes symptomatic, starting to be forgetful and all that kind of stuff. So when a person becomes symptomatic, what should we be looking for? So these are what we call the warning signs for Alzheimer's disease and actually for other forms of dementia as well. So if you have any of these, I think it's, or if you know someone who has any of these, I think it's important to get the person checked out, okay? Now, I think we all sometimes have our memory lapses. I have my memory lapses. I think too many of those. But the important thing is, do we need to be overly paranoid about it? Perhaps not. Having said that, if the memory issue is actually affecting your everyday life, then most likely there is a concern, and you need to be more careful with it. Of course, another warning symptom would be, you can do a lot of things before. These things you can do without any problem, but you start having problem doing these tasks that you were able to do without any issues, okay? Now, some people might have problem with the language. They may have like word finding difficulty. They may have a little bit of problem understanding what is written. So this could be one of the issues. They get disorientated, they get confused of where they are, what time it is, okay? Judgment becomes a little bit off, or even more than a little bit off, and people will start to have difficulty managing, for example, the finance, managing day-to-day running of their life. Someone may have difficulty understanding the abstract meaning of certain phrases. Let's give you an example. I think everyone knows what it means by don't put all your eggs in one basket, okay? So there's an abstract meaning to that phrase, that sentence. But people with cognitive difficulties, they often wouldn't understand the meaning behind these phrases. Now, it's part of the memory issues. People start to misplace things. often enough. Again, I misplace a lot of things, but if it's starting to affect your life, okay, then it's not normal. Some people may have these mood changes, personality changes, and they may act quite oddly compared to how they were before. Some of them may be quite unmotivated to do things. They're not depressed, they're not sad, but they just don't have the motivation to do anything. Okay. Medically we call that apathy. So it's basically people don't have the motivation, but they're not sad. Okay. So if there's any of these, I think it's very important that you have it's good to seek professional help. All right. So now we have talked about a lot of these so-called cognitive symptoms of dementia, memory issues, and sometimes we joke about these memory stuff. Alzheimer's disease and other forms of dementia as well, they have another collection of symptoms. Okay, these are the non-cognitive symptoms. We call it the biological and psychological symptom of dementia. Now, unfortunately, these are not symptoms to be joked around, and in fact, they're terrible. I mean, they're probably a lot worse than the so-called cognitive symptoms of dementia. Some classic examples that I see in the clinic is that the patient will be accusing others stealing things, stealing some kind of strange items. For example, stealing bowls from the kitchen, rice, okay, underwear, that kind of stuff, okay. Now, it's also very common that some of these patients, they would have this paranoid delusion about the spouse not being faithful, okay, having extramarital affairs at the age of 85, things like that. And a lot of them start wandering at night, thinking that the home is not there, so they have to pack up and leave. And some of them might present with actually depression. They get anxious. And like I said before, they can be apathic. They don't have the motivation. So why are we talking about these BPSDs? Because not only that they can be devastating, they're very, very common. I'm talking about maybe 80% of patients with dementia, they will develop one form of these BPSD. As you can see in the diagram, it ranges from depression or mania or psychotic symptoms, and some of the people can be apathic, and some get agitated, okay? And as you can see also that some of these paranoid delusions or even hallucinations, they are unpleasant, and because of you keep on thinking that your neighbor is stealing from you, it's not difficult to imagine, in fact, that you might become very very upset and become frustrated and therefore become aggressive. It's not uncommon. When I was in Hong Kong, once in a while you will hear, one elderly beat another person to death simply because of the delusions. Okay, and of course that person has the elderly who beat up the other person had Alzheimer's disease. So, like I said, all these BPSDs can be very, very disturbing, not only to the patient, but it's very difficult for patients, caregiver, family to handle. And it's very unfortunate that it's not until the presence of these type of BPSD not until then, I don't see the patient. Okay. I wish that, when people have those warning signs that we talked about, and they can start coming in and seek help rather than when they have these major BPSD issues, then come in. Because usually when the person develops this type of symptoms, it's already a little bit, the stage of the dementia is probably usually at the more moderate stage, okay? As you can see, I mean, with these difficult handling, a lot of these BPSD can lead to these patients having to go to these nursing homes, maybe prematurely sometimes. Okay? And the good news, though, having said that, a lot of these BPSDs are actually treatable. So, yeah, you might wonder why do we have these BPSDs? Now, there can be many reasons. So, the stage of the illness could be one, and the personality of the patient, it also could be a factor. As you can see here, we have many factors that can cause BPSDs, and the number of them, well, there's nothing much we can do about. Like I said, the brain, the stage of the disease is we can't change that. We can't change a life history of a person. We can't change the personality, and we can't change family history, right? But there are a lot of other causes that we may have some control. Okay, for example, if we can manage the medical problems, optimize the management of these problems, the chance of developing BPSD will be lowered. And a lot of times, depending on the severity of the illness, sometimes patients can be in pain, okay, or other forms of discomfort, but they cannot verbally tell you what's going on. And so that translates into more kicking, yelling, and biting, whatever that could be. Or there could be other forms of needs that they have, and we are not really meeting them. Okay. Now, education is very important. If we can actually, educate people who are looking after patients with dementia, that will probably empower them enough to in fact lower the incidence of these BPSD. All right, so we move on to how we treat Alzheimer's disease. Well, I'm sorry having to remind everyone that currently we do not have a cure. Having said that, I mentioned this before. If the diagnosis is made earlier, the management will be, of course, earlier, and it can actually affect the outcome quite a bit. Okay. We, of course, want to deal with the symptoms, okay? For example, the BPSDs, we want to deal with them. First line is not giving them medication, is to try to understand the problem and try to manage the situation. We de-escalate and try to manage it without medication, okay? Now for the cognitive symptoms, okay, we do have two classes of medication that can help to hopefully slow down the progress of the illness, especially the first type, the acetylcholinesterase inhibitors. There are three of them, and two of them are commonly used in Malaysia. And now, it doesn't work for everybody, but for Alzheimer's disease or Lewy body dementia, this type of medication I'm talking about, donepezil or rifostigmine, they tend to work pretty well. Okay, they would be effective in about 70% of the patient. Okay, if you start the medication early. For vascular dementia, the efficacy, the outcome is not as good. Only maybe about 30% of the patients can benefit from this type of medication, but it's still worth trying. Okay, if it doesn't work, then you can kind of take that off. So the acetylcholinesterase inhibitors and the NMDA receptor antagonists, these classes of medication are designed especially for patients with dementia. Now, as I mentioned before, the different types of BPSD, some people have depression, so we have antidepressants that we can prescribe to them. We also have, if they become psychotic, having hallucinations, or these paranoid delusions, we can use antipsychotics. Now, an example of that would be risperidone, which is quite commonly used. The one thing that, well, I'm going to kind of elaborate a little bit on this type of medication. Antipsychotics are very, very useful in helping people with these psychotic symptoms. And patients recover very quickly, okay? But the problem with antipsychotics is that we know very well from the literature that this type of medication, they're not good for people with dementia. What do I mean by not good? They actually, people die more easily. We don't know exactly why, but usually it's some cardiovascular or complication or pneumonia. So the FDA, actually, the American Food and Drug Association, they actually have these major warnings telling doctors not to use antipsychotics to treat patients with dementia. Despite the warning, most doctors, including myself, we use the medication, of course, depending on the BPSD, depending on the severity of the symptom. We use it very carefully, okay? We start the medication at a very, very low dose, and we don't titrate up the dose quickly. We'll just observe, give a little bit, and see if there's improvement. Now, another important point is that if you know anyone who's on this type of medication, sometimes the doctors might keep them on this medication indefinitely, which is a big no-no, okay? Sometimes family will actually ask the doctor, because it works so well, say, oh no, please don't take it off. So it's really up to the doctor to explain to the family that, look, we need to do that because they're not very safe, so to say. And yeah, so if the problem actually returns, then we can restart the medication. But the idea is you use as sparingly as possible, and also don't use it indefinitely, okay? Ginkgo biloba has been talked about for a long time, whether it helps the cognition. Now, there is some evidence that it might improve the cognitive functioning a little bit, and it depends also on the preparation as well. Some are better than the others, so the evidence is variable, so to say. Okay. So we talked about what actually happens in the Alzheimer's brain. So let's talk about what causes Alzheimer's. Okay. The major risk factor for Alzheimer's disease, and even for many forms of dementia, is actually age. As a person gets older, the chance of getting Alzheimer's disease will increase significantly. Now, genetics, yes, genetics can affect the development of Alzheimer's disease. Now, some people, when they have a mutation in some of these genes associated with Alzheimer's, they can get the illness very early. Some families in Sweden, they could actually get Alzheimer's as early as mid-30s. That's very rare, but this can happen. And but for Asians, the mutations are a little bit different. So we don't have as many early onset cases, so to say. Now, head injury is a known risk factor for dementia. If you know the boxer Muhammad Ali, I mean, he did have cognitive impairment down the line. And so, protect your head as much as possible. And Down syndrome is another risk factor for Alzheimer's disease because of the genetic propensity of getting the 3 copies of the genes for this protein associated with Alzheimer's disease. Now I have bolded cardiovascular disease here as risk factor. In fact, it's strangely high blood sugar, high cholesterol, high blood pressure, and being overweight, very overweight. These are probably the most important risk factors, actually, for next to age, for Alzheimer's disease. Okay. Now, it's so important that, in fact, a research group in New York, this is not new, it's they have been doing this for the past at least 15, 20 years. They call Alzheimer's disease basically is diabetes of the brain. So they call it type 3 diabetes. What they have found, in fact, 8 out of 10 people with Alzheimer's disease have type 2 diabetes, or at least insulin resistance. What does that mean? Well, it means that the brain is not really responding to insulin, which is the hormone that takes away the sugar from your blood vessels. Okay, and when that doesn't happen, your blood sugar level is very high, and when that happens, that is kind of like sugar is you can consider it as a toxin for your blood vessels. Okay, it rots your blood vessels. If your blood vessels in the brain are not healthy, okay, that means the brain cells are not getting a good enough blood supply, and so they degenerate. Okay. Now, of course, this diabetes, like type 2 diabetes, it can be influenced by many things that we do, the environment, what we eat, what we choose to exercise. Actually, exercise is one very good thing to improve the insulin sensitivity. So now, just to illustrate the importance of insulin resistance without really going into the technicalities here, in fact, when you have insulin resistance, you'll see that the brain will be having all these kind of processes. These are abnormal processes that that goes on in the brain. Remember, I mentioning, within that 2 or 3 decades, the person is not symptomatic, but a lot of damages are being done. These are the processes going on in the brain during that 20, 30 years, resulting in significant neuronal death. So this is a problem with type 3 diabetes or Alzheimer's disease, having having high blood sugar in the brain's blood vessels. Okay, now this is it has been 9 years already. This is a very prominent study in Finland with geriatric patients. They call it the finger study. They took over 1,000 people who are kind of having a little bit of cognitive issues. Okay, they separate them into 2 groups. One group is just conventional medical checkup, and that's it. Okay, of course you take the medication still and all that. And the other group, what they did was they provide nutritional counseling, and they have exercise program, and they also have these cognitive training programs, right? And they really optimize the management of the diabetes, the blood pressure, and the cholesterol, okay, for 2 years. After the 2 years, they found there was a significant difference in terms of cognitive performance between the 2 groups, okay? So, of course, you can you can guess which group was better than the other one, right? The one with the intensive intervention, as I'm showing here, is way better than the group assigned to just regular healthcare. Okay. So from this study, the outcome is really they have developed this so-called multi-domain approach in tackling dementia. Basically, it's like risk factor elimination, and also have this protective factors to establish these protective factors for these for individuals. So, in the green, the genes is nothing much we can do about that. So, but then in terms of the risk factor control, I mentioned already the diet, for smoking, alcohol, and depression. I would talk a little bit more about that later. And like I said, controlling blood pressure and optimize person weight and also cholesterol level. These are the risk factor control. Combining that with education, physical activities, and keeping your mind active as protective factors, the cognitive outcome is usually the best. Right. So, like I said, I would talk a little bit more about this mixed dementia concept. I remember when I was in medical school, my professors was very adamant to teaching us how to distinguish between Alzheimer's disease and vascular dementia. Okay, that was many years ago. But these days, as we know a lot more about Alzheimer's disease, both from a molecular standpoint and also from a clinical standpoint, we know that in fact, Alzheimer's disease and vascular dementia, the boundary is actually rather blurred, okay? It's no clear boundary. We diagnose Alzheimer's disease clinically, you have these impairments and things like that. And they usually have a lot of these protein deposits in the brain. Now, for vascular, now, in addition to that, what we know, back then, we didn't have the technology, so it's not until autopsy, okay, when we cut open the brain, when the person has passed on, we see that there's a lot of vascular damages in the brain, in these Alzheimer's disease brains, okay. Now, with imaging, we can see that. We don't have to wait until the person passes on. You can see, if you do a CT scan or MRI for patients with Alzheimer's, a lot of times you see all these, we call them lacunes or white matter lesions. These signify the vascular damages in these brains. So a lot of people with Alzheimer's disease, in fact, they do have a lot of vascular morbidities in the brain. So we now tend to diagnose people a lot more with this condition called mixed dementia rather than pure Alzheimer's disease. Okay. Again, this is another indication of how important vascular health is in the etiology for the development of Alzheimer's disease. I think this is what you come here for, to find answer to this question. And unfortunately, I'm going to disappoint you because if I had the answer to this, I probably wouldn't be here. So we have researched on a lot of these different things, and is it genetics? Yes, and like I said, it's partially genetics, and unfortunately, being a woman, you do have a higher chance. Now, is it because we don't get enough nutrients? A possibility, but that is usually reversible. Let's say if you don't have enough thiamine or vitamins or B12, folate, that kind of stuff, yeah, your cognitive function might be jeopardized. But if you replenish the person with the nutrients, yeah, it's I would say it's more reversible. Okay. Now, can you prevent having dementia by playing mahjong or playing Sudoku? The quick answer is no. People still get it. And I don't know if you recall aluminium. People were worried that that could be a cause for Alzheimer's disease. So there was a period of time where people really threw out all their aluminum cooking pans and got something else, Infection, well, the certain infections might be the culprit for dementia, but it's not huge, okay? So by controlling these things, or we can't control being a woman or not, but by even controlling all these other factors, you can't really prevent dementia, okay? So, sorry, like I said, being very disappointing here. But I think it's more realistic to talk about how you can reduce your risk of getting dementia as much as possible by staying physically active. Again, I know I'm being very long-winded. It's all about maintaining your cardiovascular health. Now, am I saying that if you don't have high blood pressure, don't have high sugar, high cholesterol, you won't get dementia? I never said that, but it will really reduce your risk. And it's something that you can do, okay, to quite well, easy enough, all right, to reduce that risk. Right? Avoid isolation. It's another thing. Being socially active, have friends. Sometimes, elderly people, when they are no longer working, there's a loss. They don't want to go out. They hide themselves, and sometimes they think that they are burdens. So those things are very negative for the brain. So challenge your brain. Okay, although it doesn't prevent. Okay, it's never any harm doing Sudoku or even playing Scrabble. It doesn't have to be Mahjong. Okay, you can play Scrabble, you can play chess, things that can basically keep your brain active. Crossword puzzles, okay. Healthy eating, okay. Balanced diet, I think is important. And you don't have to be doing those intermittent fasting, this type of diet, that type of diet, just basically balanced, healthy eating, okay? Now, like I said, head injury is huge risk factor, so be safe. Try not to do things like too many bungee jumping, skydiving, and stuff that can hurt your head. There is good evidence that a glass of wine is actually not so bad. But when you have 2 bottles a day, that's not the same. So limit alcohol use, because, for example, red wine has very good source of antioxidants. Smoking is huge. If you could stop, I think it's important. Now, it's not easy. I'm sure that actually Hemingway he had this saying that giving up smoking is the easiest thing. I have done it many times. It's important to understand why you want to stop. Plan it out well. I mean, cold turkey is perhaps not for everybody. Stopping smoking is important because it really ruins your cardiovascular health. Going to be a little bit sidetracked here. When we first look at Alzheimer's patients, we thought that, in fact, we thought smoking was a protective factor for Alzheimer's disease because of the nicotine. But we were wrong, very wrong, because a lot of these smokers who actually they die too early to develop Alzheimer's later on down the line. So smoking is not a protective factor for Alzheimer's. Do your medical checkup. Sometimes I see my elderly patients and I ask them about their medical history, and they will say that they are fine. Then my next question would be, when was the last time you do your medical checkup? Some of them will tell me 20 years ago. Of course, you don't check, everything is fine. So medical checkup yearly is, if you really don't have anything, then every year at least once would be very good. Now, like I said, I was going to talk about depression. Depression is actually, this is part of my earlier research as well, looking at it from more of a molecular standpoint. We know very well now that depression, even, I'm not talking about late life depression, when you're adult or teenager, earlier life depression is a significant risk factor for later life dementia. So managing your stress, being more resilient, I think these are important. It's another thing about depression I think I should mention is that some people, they think that they really have this Alzheimer's, they can't remember anything. In fact, it's not they have Alzheimer's, but they have depression, okay? Why don't they remember in people with depression? Because when a person is depressed, the concentration is very much affected. Okay, so if you can't concentrate, if you can't pay attention, a lot of things that you're supposed to hear, you don't hear. Of course, if nothing has gone in, you can't get them back out. Okay, so some people might actually have depression rather than dementia. Okay, so that's why I think when you have these cognitive issues, it's best to have it checked out by a professional. I think that this is about all I have to say, really. Now, going back to the take-home messages, we have talked about this. I hope by now you really would understand that dementia, it is an illness, okay? And we have talked about the different warning signs, okay? Some of them are non-cognitive, meaning that it's about personality, it's about the mood, okay? So be aware of that. We can actually sustain a very high quality of life if people can come in and have earlier management. Okay, we have discussed how Alzheimer's disease is type 3 diabetes, and again, being very long-winded, the better the blood, the better the brain. So to close, before answering questions, I just want to pay my tribute to people who are caregivers of patients with Alzheimer's. It is a very difficult job, okay? I mean, caregivers, as in, it could be a family member, it could be caregiver in a home, or, it's very difficult. And I think it's important for the caregivers to really understand their limitations, and there's only so much that they can do, because sometimes they go far and beyond to help the patients, and in a way losing themselves during the process. So, and I often say to my students, I say, when you look after patients with dementia, don't forget about the family. They could be your hidden patients, okay? And it is so true. The thing is, if you don't ask them how they are feeling, how they're doing, they won't tell you. They'll be this strong person, right? But if you listen to the stories, listen to how they are managing, you can appreciate how much struggle that they can be in. And if you ask them just one question, how are you doing? A lot of them, they end up, bursting in tears, telling you how difficult things are. Okay, so don't forget them. Okay, so I think that's all I have to say. It's not an hour. So I'm happy to answer any questions or to discuss anything.
Okay, so I'll just put up the questions that have been asked via the Google Forms earlier. So we start with question 1. How to socialize with people living with dementia disease?
Yeah, I think it is a wonderful question. I think it's important to know this. Now, before actually going to the socializing part, I think we have to have a better understanding of what dementia is and what the symptoms are and why they are this way. And I think another point that we have to always remember is that we are seeing a patient here. this person is unwell. Sometimes I think, especially family members, it can be difficult. It can be very frustrating. Okay, so we have to take a step back and reorientate ourselves to think that, okay, this is a patient. I'm telling you this because as a son of a mother with some cognitive difficulties, sometimes you get so frustrated. Sometimes she remembers well, sometimes she doesn't. So it's kind of these selective dementia is difficult. But I think to communicate with patients with dementia, you need to be patient. You never want to escalate the situation by understanding that, well, sometimes you're saying that they keep on asking the same question over and over again. I mean, you can tell them, oh, you actually have asked me this already. But yeah, let me tell you. I mean, you need to have a lot of patience. You can redirect the person. Okay, there's nothing wrong with that. You can so-called challenge the patient, but not in a unfriendly kind of way. Or sometimes you may want to kind of like, what do you think? What do you think we can do? Or what would you like to do? Give them the voice, okay, and see what they say. Sometimes they might not be the most coherent, but at the same time, well, by allowing them to actually say what they have to, what they're thinking, is probably it helps you to understand how severe they are, or how to kind of move into their thinking process. Okay. What was the question again? How do you communicate with?
Yeah, how to socialize with people living in dementia disease.
Yeah, I think that's those are the main point. It's not to escalate, to understand where they're trying to understand where they're coming from, and if you really have problem, I think it's important to share it with professionals. And sometimes, occupational therapists are great in terms of helping family members or caregivers to deal with patients with having cognitive difficulties. And like I said, I think with the cognitive issues are probably easier to handle, so to say, as compared to these behavioral problems.
Thank you so much. Prof, second question is, just want to improve the brain memory, because most of the people, they say they cannot remember the names and the things they do easily.
Yeah, I you know what? To improve is probably not too possible, so to say. But I think we can do things to help ourselves. Okay. For example, I think we probably need to pay more attention to things so that we focus. If we try to focus when we're working on something, we try to focus more on it. And as we age, we probably need more time, okay, to learn new things. Make extra efforts to, let's say, remember names and things like that. I'm very poor sometimes with remembering names, especially some cultures, they have these really long names. I get very confused myself. But you can, well, maybe you can write them down. You can jot them down. You can ask, okay, how do you say this? And you practice. I think these are probably the more realistic way of so-called improving your memory. Cognitive training, playing these games, I think they can be very helpful. Even on your phone, there are a lot of these kind of good brain training games that might help a bit as well. So, but I think if you're talking about what is anything to eat or anything, to improve your memory, there's no good evidence for it, apart from ginkgo. But that's more for people who already, have some cognitive difficulty.
Understand, Prof. Thank you, Prof. Then another question: can tocotrienol help to slow down the development of dementia?
The quick answer is no. These vitamin E analogs, we don't have studies. There's no evidence that they can actually slow down the dementing process. Having said that, there are studies that support this type of supplements in terms of improving cardiovascular health or maybe lower cholesterol. Okay. Now, again, I mean, indirectly, you can say that if you can improve the cardiovascular health, then yeah, maybe you help the cognitive function. But there's no direct evidence that can slow down the dementing process.
Got it. Well, next question is: what is the most cognitive changes during aging process?
Most cognitive. Well, it usually, okay, you're talking about, I guess the question is about normal aging.
Yes.
For normal aging, I think, yes, we do have some memory lapses, okay. The processing speed is probably slower, okay, and decreased. And your ability to learn new things, you can. Don't get me wrong. I mean, there's a saying that old dogs can't learn new traits. Totally not true. You can. Okay. But it takes longer. Okay. And but all these are normal aging. Okay. Now, of course, for abnormal aging, then depending on the type depending on the types of dementia you're talking about, for, let's say, Alzheimer's disease, usually it's the memory. Okay, for Lewy body dementia, because like I said, it's closely related to Parkinson's, sometimes they may have the movement disorder first. And also they will have these what we call visual spatial difficulties. They are seeing things, very vivid images. They tend to see little people walking around. They see other forms of visual hallucinations, but the memory is still pretty much intact. And there's another type, which is called frontotemporal dementia, that happens quite a bit earlier than Alzheimer's disease. It can happen quite a bit earlier than Alzheimer's, typically around mid-50s. With that, again, at the beginning, it's not the memory, it's the personality, it's the behavior or the language, okay? So depending on the type of dementia, different symptoms happens first. And for normal aging, like I said, it's about processing speed. It's probably the main thing. So.
Thank you, Rob. Another question: is dementia hereditary?
Partially it is, okay. We talked about the genetic aspects of Alzheimer's disease. In fact, yeah, if you have mutation in one of those three genes, we're talking about the amyloid precursor protein gene, the presenilin 1 or the presenilin 2 genes. If you have mutations in those, yeah, you will get Alzheimer's. But a lot of people don't have those. A lot of people have these different variants of another protein, which is used for cholesterol metabolism. Talking about things like apolipoprotein E. People have different variants of this, and these are what we call risk factor genes. If you have certain allele, certain variant, you might be more prone to getting Alzheimer's, but it's not definite. Okay, you can still, it depends on what you do with yourself, you can still live very healthy until the end and without dementia. So those are, like I said, risk factor genes that may or may not lead to Alzheimer's disease. So I think the quick answer is yes, it can be hereditary.
Prof, one question from my side I wanted to ask. Has the incidence of dementia increased after the COVID pandemic? Is it something to do with the psychology of the people, or is it something to do with the disease itself?
I think with or without COVID, Alzheimer's is going to, or dementia in general, is going to the incident prevalence is going to increase, simply because there are more and more elderly people around. Okay, Malaysia is aging very quickly, and down south in Singapore is the same thing. I was just talking to someone last night. It's a huge problem down in Singapore as well. So it's not just that. I mean, in Canada, in US, it's the same thing. So, but over there, they have maybe they are better equipped to deal with that as compared to a number of Asian places.
Thank you, Prof. To all the audience members, if you have any more questions, please type in the chat box. You can even raise your hand, so I'll unmute the mic. If you want to ask any questions yourself, please let us know.
Yeah, do that, and I'm happy to answer. I may not have all the answers, of course.
Yeah. Okay, we have one more question.
Okay.
Prof, how to diagnose early dementia? I mean, if someone regularly goes for medical checkup, I don't think the person would go for brain imaging or scans. So how can that person know if they have dementia?
Okay. Like I said, okay, if you do have the warning signs, all right, and if you do go and to the doctor, okay, with the warning signs, the doctor will be asking you the history, what's going on, okay, in terms of the memory issues, when did it start, and how has it been progressing, and all these other symptoms related to a dementing illness. The doctor will ask you about that. Now, one important, what we call differential, one thing that we need to rule out is that you're not depressed, okay? Because like I said, depression can appear similar to someone who has a dementing illness. So we need to rule that out. And we need to actually do a number of tests, blood tests, to make sure that it's nothing medical. For example, like folate, if you're nutritionally deficient, that can cause cognitive impairment. And we'll check your liver, check your kidney, and all that kind of things. Now, we also would do a screening test. In my clinic, well, I think a lot of people, they used to do the what we call the mini mental status examination. It's a very crude kind of cognitive test. So I tend to use something called the Montreal Cognitive Assessment. There's another one, I mean, the Cambridge has also got one, but that is much longer. So for the time and for the accuracy in combination, the Montreal Cognitive Assessment is a very sensitive test for early dementia. Okay, it picks up it picks up the impairment a lot better than the MMSE, the Minimum Mental Status Examination. So we'll do that too. Now, with all these together, okay, we can actually diagnose dementia at an earlier stage, or is it mild cognitive impairment before even being considered a person that has dementia. There's a stage called MCI, mild cognitive impairment, and some people could just stay at that age, that stage, and not progress. Okay, but once you reach the dementia stage, then the usual outcome is that there is progression from that point on. No, you don't go for imaging all the time, of course, for a brain scan, but to diagnose, okay, it's not 100%, but I usually would ask for at least a CT scan of the head, depending on your kidney function. If your kidneys are good, I'll do the scan with the dye so that it shows more details. But if the person has dementia, there are some features that we can see. Now, another thing that I didn't mention this, but I guess I should as well. It's another reason why sometimes I would want to do a CT imaging, because I've had this patient is quite some time ago now. She came in with the daughter, and this person was basically showing classic Alzheimer's symptom. Okay. And the rest of the exam, neurological exam, everything was fine. There's nothing except for memory issues. Okay, it's bread and butter Alzheimer's disease. I wanted to do an imaging because I'm thinking that, okay, with the film in my hand, I can show the patient, look, this is the problem that we are having, so that I can convince her that she has problems. So, but unfortunately, after the scan, what we saw was a huge tumor in part of the brain, and it's starting to compress onto the midbrain. So we were lucky that we caught that. So I had to transfer her to a neurosurgeon and see what could be done. But you see, sometimes, rarely, people with cognitive impairment could be because of a tumor, but usually the person will have other signs. You can, on a physical exam, you can tell. But so yeah, so there's a scan can be helpful. So in terms of diagnosing earlier dementia, is when you have the warning signs, you come in, we do a screening test, and we check the other blood parameters, and this is how you do it.
Thank you, Prof. Thank you so much. On behalf of everyone here today, I sincere thank you for taking time out of your busy schedule and speaking to us about such an important topic that we often tend to ignore. The points you mentioned regarding recognizing the early signs and ways to reduce the risk of dementia, they are going to help us a lot, and will able to help others also.